Hello, my name is Reina Fonseca, representing Benedictine University's Research Methods in Public Health, presenting health equity for women in inner cities with co-authors Anna Moran, Chelsea Griffin, Maggie Keck, and Catherine Mitchell. Inner city populations have long been considered amongst the nation's most vulnerable. The intergenerational transmission of poverty and poor health persists in part due to inadequate access to care, which is further compounded by adverse social and environmental risk factors. Racial minorities and women are known to receive disproportionately poorer quality of health care when compared to non-Hispanic whites. Literature suggests that African American women receive lower quality of care and have higher mortality rates than all other individuals. Furthermore, females receive less aggressive pain management than men with post-surgical care, metastatic cancer pain, AIDS, and other comparable diseases. Therefore, we ask the question, is there a gap in equitable access to pain management for minority women in urban environments, and does that lead to disproportionately poor health outcomes? We performed a search for peer-reviewed literature regarding women's health. Many studies analyzed women's health in general, compared access to care between men and women, and made comparisons in health disparities amongst women that resided in rural and urban geographical locations. In the past 5 years, research was conducted that examined the well-being of minority women living in metropolitan America, but have only focused primarily on one minority race or women as a group. We found that the gap in research studies is the healthcare disparities in terms of pain management that all minority women living in metropolitan cities are experiencing. Our target demographics are adult biological females who are not pregnant and aged 18 or older of Black and non-white Hispanic ethnicities within the Detroit and Chicago areas, having documented histories of seeking management care for acute and/or chronic pain. We will exclude non-female and pregnant female participants that reside outside of Chicago or Detroit, are under the age of 18 with ethnicities of white Hispanic, Asian American, Pacific Islander, Native American, and any other non-minority ethnic backgrounds. These excluded participants will have not sought management care for pain and for conditions that could confound the outcome. This visual of our target population shows our planned recruitment approach. Working through the community with patient advocates, healthcare providers, community organizations as well will help us identify and recruit patients. Additionally, social media and online health platforms, along with other methods of sampling, will be used to ensure proper sample size. We will focus on two recruitment approaches, proposive sampling and snowball sampling. Proposive sampling allows us to recruit our target population of minority women out of Detroit and Chicago at convenient locations working with community organizations. Selected participants are those with varied experiences and outcomes when seeking pain management care. Employing the secondary method, snowball sampling, will ensure a sample size large enough in the case of a low recruitment rate with the primary method. These participants are those minority women who have sought pain management care and are referred by initial recruits who in turn receive an incentive. We will ensure this study has a substantial sample size, broad representation, and limited biases. Potential confounders include socioeconomic status with regard to education, employment, and income, health literacy and health insurance coverage type, language barriers, and beliefs. The ease of access and the quality of facilities within these cities, as well as lifestyle behaviors and quality of life, are key factors in our study. We will discover these confounders through surveys and questionnaires. Prior to the start of the study, all participants will complete an informed consent form explaining the goal of our research, the information that will be collected, and how the information will be used, and most importantly, how their confidentiality will be protected. We will be utilizing the recursion policy, which states that all records from the study will be kept confidential and participants will not be identified by name, address, or other direct identifiers on any study-related documents. Instead, participants will be assigned a unique identification number that will appear on all study-related documents. Study records will be retained for a period of 5 years, then will be disposed of by either clearing the data or digital shredding. We submitted an IRB application through Benedictine University with Dr. Clay as our advisor on the project. To assess pain quantitatively, we will use numerical rating scales where participants are able to rate their pain on a scale from 0 to 10, and a visual analog scale for participants to mark a point on a line representing the intensity of their pain. Finding out how satisfied a patient is with their pain management is important to our study. This will be answered with a questionnaire to measure the effectiveness, communication, accessibility, and overall satisfaction with care. Satisfaction will also be measured with a consumer assessment of healthcare providers and systems survey, which assesses the patient's experience with overall healthcare systems. Other forms of data collection will include questionnaires that target health disparities to assess patients' perceptions of their accessibility to care and equitable treatment compared to others. Our use of the SF36 Health Survey will assess participants' quality of life as it relates to aspects of overall health and needs. We will simultaneously use quantitative questionnaires before and after collecting our qualitative data, utilizing ground theory, where we will collect and analyze our data from the aforementioned quantitative data collection to find patterns prior to performing face-to-face individual semi-structured interviews. The field work will include real-time community and cultural observations of the women residing in the inner cities of Detroit and Chicago, as in the observer as participant point of view. Observational data will be used as supplemental data to the remaining collected data. Here, you can see a sample of the interview guide. The primary goal of our interviews with participants is to understand the experiences of minority women with pain management. The interviews will collect their demographic information, such as age, ethnicity, residence and treatment locations, as well as some background on their pain condition and additional comorbidities. The interview will transition to their experience with seeking healthcare and treatment options. Quality of life will be discussed, and any additional challenges or barriers that have affected the participants' pain management will also be discussed. The interview will close by asking participants if they have any suggestions for improvement. Here's a short sample of the semi-structured interview. The questions may lead to other prompts based on participants' responses and what they are willing to share. This descriptive analysis provides a further understanding of the study's variables to allow characterization of the study's population, describe key outcomes, and identify patterns that can inform analyses or interventions. The unadjusted analysis plays an important role in the context of these studies because it provides a foundational understanding between pain management, patient satisfaction, health disparities, and quality of life measures by generating hypotheses, understanding baseline associations, and identifying initial patterns that can further guide in the refinement of research questions. Organizing the qualitative data will consist of transcribing interviews and focus group notes verbatim, adding annotations as needed. Once the transcripts are created, a codebook will be developed to assist with translating the data into themes and concepts. During this process, a QDA protocol will be created. This protocol will ensure all investigators are on the same page, as well as avoiding biases when analyzing the data. To further analyze the qualitative and quantitative data, method triangulation, specifically simultaneous triangulation, will be useful to cross-validate our findings using more than one method. To retain participants, we will offer video chats and phone calls if participants are unable to have face-to-face contact. Compensation will be provided to further entice the participants to maintain their participation in the research program. Here are our references. Thank you to the entire author group and to Dr. Clay, as well as Benedictine